talk. We're giving the talk at noon our time in the United States, and is it 5 p.m. in Hungary right now, or is it 6 p.m.?
5 p.m.
5 p.m.
5. Okay, so we changed before you. So 5
Hello, Laszlo. Hello.
So, Robert.
Yes, here.
So just let me introduce Dr. Robert Reisch, who obviously has a busy day and was kind enough to give a lecture. His lecture will be on endoscopic transnasal surgery of the pituitary gland and where we stand today. He has he comes from studying at Semmelweis, and then he also studied in Mainz, Germany, and now he is at the head for the Center of Endoscopic Minimally Invasive Neurosurgery in Zurich, Switzerland. He's got a special interest in microneurosurgical anatomy, neuroendoscopy, and minimal invasive neurosurgery and keyhole neurosurgery. The Mind series of lectures invites lecturers from all over the world, not just in the neuroscience, but in other fields. And it's been quite popular, and especially due to the pandemic, and we'll continue this because I think the world is much smaller than we think it is, and we exchange information from different parts of the world, and it's really encouraging that I have Dr. Reisch, who has been successful in Germany and in Switzerland, and now is here giving his lecture. Robert, thank you very much for being here today.
Laszlo, thank you much for your invitation. We are just still in the operating theater, finishing a surgery. A patient from Hungary, from Budapest, with a glioblastoma. We treated together surgically and neuro-oncologically. And now I intend to give this short lecture about endoscopic techniques, neuroendoscopy, and mainly on transnasal neurosurgery. Do you have any questions during my lecture, please don't hesitate to interrupt me. I think it's a very informal lecture about these concepts. Please, this is a very open discussion. So then I start now the presentation. Okay, let's stop. Okay, are you able now to see my lecture, my presentation? Laszlo?
Not yet, not yet. We don't see it.
Not yet, okay.
Should we share screen?
Yeah, I am just doing it. Ja, Bildschirm freigeben, ja. Dateien. Desktop is what I did. Dropbox. Nein, das ist Bildschirm, das ist wieder.
Ist der Einstellungen öffnen? Aha, da ist irgendwas da. You have to solve a problem. Ein System-Einstellungen von dem Computer. Da. Dort schauen. Ja, genau.
Aber das ist nicht aktiv.
Ja, musst du wieder auf den Dock drücken, deinen Code eingeben von dem Computer.
Ja.
So.
Yes. Okay.
Auch die andere.
Dann.
Ja, da musst du nochmal öffnen.
Auch eine Presentation.
Ja, man ist okay,
Ja. Okay, und jetzt?
Wenn ihr merkt, dass die lesen, ist neu öffnen.
Okay. We just need 1 minute to open the presentation. Okay.
Nein, da, super.
No. Okay. Okay. Super.
Okay.
Perfect.
You see it now?
Yes, you just want us to. Perfect.
Okay.
még ezt a középső a másodszor balról.
So let's start the short presentation. My topic is today neuroendoscopy and minimal invasive techniques in brain and skull surgery, concentrating on transnasal operations. I think the main goal in modern brain and skull surgery is very clear. This is nothing else than to achieve the best possible surgical result in a safe and gentle way, avoiding unnecessary approach-related injury of the patients. In my hands, we are using minimally invasive and endoscopic approaches in our daily routine. I've learned these techniques more than 20 years ago during my residency time in Mainz, by Axel Pernetsky, who was also born in Budapest and one of the most famous endoscopic neurosurgeon and my teacher and mentor in this field of neuroendoscopy. The highlights of endoscopy are the enlarged field of view during the surgery, the improved light intensity, and increased focus range. You see now on the screen on the left side, intraoperative situation treating a trigeminal neuralgia. And this is the view of the microscope. You see just here a jungle of vessels. You see here somewhere the trigeminal nerve, but you don't have a real overview of the situation. If you introduce in the same situation an endoscope into the field, then you have a beautiful overview. You see here the tentorium, you see the skull base, you see the trigeminal nerve, you see in the background even the abducent nerve. You see here the petrous vein, and just in the background, the superior cerebral artery compressing severely the trigeminal nerve. The nerve is almost translucent here, according to the compression. With endoscope, you have not only the overview, you have also control on the dissection. Here in this case, my plan was to mobilize the superior cerebral artery between the tentorium and between the petrous vein. But with the endoscope, and just with endoscope, I was able to realize the situation that the superior cerebral artery gives some perforators supplying the trigeminal nerve and the brainstem. That means with the use of the endoscope, I was able to increase the intraoperative safety. Overview, control, and safety, they are the main important issues by neuroendoscopy. You see here now this Teflon interponate between the vessel and between the trigeminal nerve. The main indications in cranial neurosurgery are the transcranial, transventricular, and transnasal surgery. Today, I concentrate on transnasal application. And this is what we have today in most neurosurgical departments. And this is the microsurgical microsurface technique in transnasal surgery. And we can ask us, of course, why should we use an endoscope? We neurosurgeons like to operate with a microscope. We have a perfect illumination, magnification, stereoscopic visualization, easy zooming, focusing function, bimanual dissection. And we can have also a valuable surgical assistance. Why the endoscopy? The answer is that time changed. After the first description from Jules Hardy, almost 60 years ago, the technique has changed today, and we have no other options to increase this intraoperative safety and resection control. And this is why we use endoscope, because we have with the microscope and limited visualization and maneuverability in the depth. This is just a schematic drawing showing the situation with the microscope. We have a very long and narrow surgical corridor, and we see just the middle part of the skull base. And this is an interesting publication from the most experienced transnasal surgical group in Germany, from Rudolf Fahlbusch. He operated patients with microadenomas, 85 patients, and as Professor Fahlbusch mentioned that the tumor is completely removed, the colleagues performed an MRI scan, and they have seen in 42% of patients a definite tumor remnants, which was not overviewed by the surgeon. And please note, this is not a new knowledge. This is a publication which is more than 15 years old. Another publication from Dan Kelly from the US, even 15 years old, has operated patients. They were operated previously with a microscope, and in all patients with residual tumors, he have seen a suboptimal bone exposure of the skull base, and it was, in the opinion of the surgeons, because of the not complete tumor removal. And this is here a case which was operated in other institution with this microadenoma. You see before the surgery and after the surgery, and this surgeon removed just a very small part of the tumor, had even the bleeding in the tumor. And this is now here the CT scan, and you see that the surgeon overviewed just this very, very small part of the bone. This was the opening of the bony skull base, and it is not a surprise that this tumor couldn't be removed completely. This was the main cause of the suboptimal surgical result. And this is what we have seen then during the surgery by my endoscopic resection. You see now with the endoscope, the central skull base. With the endoscope, I'm able to overview here the skull base. This is the optic nerve on the left side, on the left side. This is the carotid artery on the right side, on the left side. This is the clivus, this is the central skull base. And this is here the cellar floor, which has to be opened for the surgical removal of the tumor. But the previous surgeon opened just this one here because he was not able to overview here the optic nerve, the carotid artery on both sides. And this is what led to the suboptimal removal. This is another example. This is a patient with a clavicle also operated by a microscopic-based neurosurgeon here in Switzerland. And you see here the postoperative result. According to the long and narrow surgical corridor, the surgeon overviewed just the mid part of the tumor and had here relevant residue of the tumor on both sides, even clivally, and here on both cavernous sides. And this is not an optimal surgical result. My problem is not the microscope. My problem is mainly the nasal speculum, because the speculum creates this very, very long and narrow corridor, and then in the lateral parts, you don't have the overview and the control on your manipulation. And I compare it in my presentation to a blinker for the horse that you see just straight forward and not to the sea. And as you see on this picture, to use a blinker during the surgery, it can be very, very dangerous. If you introduce the endoscope in the same surgical site, you have, as I mentioned at the beginning of my presentation, an improved visualization and increased manipulation without the speculum, with the best possible tumor resection. And this is even a publication from Ted Schwartz. He used an intraoperative MRI scan by removal of pituitary macroadenomas, and using an intraoperative MRI scan, he have seen with the endoscopic technique less residue of the tumor than reported following microscope-based surgeries. However, the endoscopic technique can be also analyzed in a critical way, because several neurosurgeons use extended approaches, removing important structures in the nasal cavity. For example, the most famous surgical group from Emin Kasem reported the technique, and in every single case, the colleagues removed the middle turbinate just to reach the skull base. Other neurosurgeons remove large parts of the septum, of the nasal septum, and even the middle turbinate. And this is an approach-related traumatization according to the technique, which has to be minimized, in my opinion. And this is the two that some neurosurgeons ignore the nose, operating like a butcher in the nose. And this is even a surgical case. You see after an endoscopic procedure, here the nasal cavity. This is the nasal septum. This is the middle turbinate. You see by beginning of the operation, adhesions. You see a purulent secretion in the nose. And this is after an endoscopic procedure. You see, if we go in the depth, you see a large resection of the middle turbinate. You see a scarring tissue between the two middle turbinates, and this patient suffers from the endoscopic procedure. And because of this ignoration is with septal perforations, castrations, adhesions, and chronic rhinosinusitis, it can damage patients' quality of life. And this is also an important issue, and some neurosurgeons do not know how important the nasal function is. And this is what rhinologists very well known, that chronic rhinosinusitis has a significant impact on quality of life, demonstrating greater impact on bodily pain and social functioning than angina, for example, or COPD. The nose is very, very important. That means we would like to have a technique in which we have a good overview, a perfect control on the tumor resection, but without damaging the nasal cavity. And the question is, how can we achieve this concept, this goal? And this is a concept in the Hirslanden skull base center. This is to achieve the best possible tumor removal with a minimum of nasal morbidity, with preservation of the midline olfactory mucosa, with minimized posterior septal resection, avoidance of middle turbinate resection. If the patient has this midline structure still after the surgery, and this is the key of an improved quality of life after the operation. Our concept is a tailored approaching of the nasal cavity. This is a schematic drawing of the nasal cavity. You see here the septum, you see here the structures of the ethmoid with the uncinate process, with the middle turbinate, the ethmoid cells. Operating on small tumors with large noses, we just use the direct paraseptal transnasal approach with opening of the anterior wall of the sphenoid sinus. Then we can overview with the endoscope the carotid arteries, and we can remove a smaller tumor. If we need a larger approach or the nasal cavity is narrow, we never remove the turbinates and never remove the nasal septum. We go more laterally and we use a transethmoidal approach. That means we remove cells of the ethmoid labyrinth, and then we can push the middle and the superior turbinates to the side, and in this way we can create a larger surgical pathway to the skull base. If we need more space, but only if it's necessary, then we use biportal approaches. That means we use both nasal nostrils, even with both-sided ethmoidectomies. And if it's necessary and the tumor is large, infiltrating even the anterior or middle fossa, then we use in selected cases a combination of a transnasal operation with different transcranial approaches, like a subfrontal, supraorbital, perional, subtemporal, or retrosigmoidal approach. The workhorse approach of transnasal endoscopy in our center is the transethmoid paraseptal approach. As I mentioned, the concept is to perform a unilateral approach, a partial ethmoidectomy, a turbinate lateralization with limited posterior septectomy, and a wide anterior sphenoidectomy. The main indications are macroadenomas and central skull-based tumors. And this is an illustrative case for this approach. This is a young lady with an adenoma, with a macroadenoma, hyperprolactinoma, according to the still phenomenon, but is not a prolactinoma. You see here on the coronal picture here, this is a septum in the sphenoid sinus. This is the macroadenoma. This is here the pituitary gland compressed by the tumor. And this is now the surgical approach. We are coming from the left side. You see on the left side here, the nasal septum. You see here the middle turbinate, and here you see the ethmoid region. And at the beginning of the surgery, we are just going not medially between the turbinate and the septum. We don't touch the middle turbinate. We are going into the ethmoid, in the ethmoid with a straightforward and very clear dissection, with a sharp dissection. We remove here at first the unsnit process. We have a view into the ethmoid cells. You see here even the maxillary sinus. Then we open here the ethmoid bulla, the anterior wall of the bulla. Then even with the sharp cutting instruments, without tearing the nasal mucosa, we are dissecting step by step into the ethmoid. In the ethmoid, we are able now here to see the sphenoid sinus. The posterior ethmoid cells are also removed with 2 cutting instruments. And then we have now the lateral transethmoidal approach of the sphenoid sinus. You see in the background the sphenoid sinus. This is the opening of the anterior wall. We see here the optic nerve. We see the optocarotid recess, and here the carotid artery. This is the first step of the approach, the ethmoidectomy. The second step is the transnasal part. Now, please note, we don't cut the middle turbinate. We just lateralize the middle turbinate. This is a very gentle massage of the turbinate. And now we have space for the middle turbinate because we have performed previously the ethmoidectomy. You see now here, this is here the natural ostium into the sphenoid sinus. We protect the nasal mucosa with paddies. My colleagues from the rhinology deal with the nasal mucosa sometimes more gentle than some neurosurgeons with the cortical surface, because we know that the nasal mucosa has a very important role in nasal functions. Now we are dissecting the midline. This is the vomer. We remove the vomer. We perform the wide anterior sphenoidotomy. This is here the septum, which we have seen in the previous MRI scans in the sphenoid sinus. And we know from the previous MRI scans, this is the septum, which show us exactly the location of the tumor. And this is now the approach, the transethmoidal paraseptal approach to the central skull base without damaging nasal anatomy and nasal functions. The next step is then the removal of the tumor. After the most important part of the operation, this is namely the approach. And now with a diamond drill, I'm opening the central skull base in a perfect visual control. You see here the optic nerve on the left side. You see the optic nerve on the right side. You see the carotid artery on the right and the left side. And now the skull base is still open. The bone is removed. Now with a 2-cutting small knife, I open the dura. The soft tumor tissue is still coming out. The dural opening is now enlarged with 2 cutting scissors, but even with non-stop and perfect visual control here on the carotid artery and the optic nerve. Then we use some curettes for the removal of the soft tumor tissue. This is just for the histopathological investigation. And now I use some paddies, and now I can dissect the sheath of the tumor. This is normal pituitary gland, and with neurosurgical paddies, I see I have removed the tumor completely. I see here the cavernous sinus. I see here still the carotid artery. This is the removal of the tumor, which was overviewed perfectly with the endoscope. And this is now the postoperative image. And the first postoperative day in the MRI scan, we see just the resection cavity of the tumor and and the pituitary gland with the control removal. The question is to neurosurgeons, what do you need for implementation of this technique in the daily routine? Is it necessary and important to have experience in microscope-based transnasal surgery? In my opinion, it is not necessary. The next generation of neurosurgeons will operate transnasally with the endoscope without using the surgical microscope. But indeed, this is a technical knowledge with the preoperative workup, patient's preparation, surgical dissection, equipment. We need a new anatomical knowledge and experience of nasal cavities, and of course, a rhinological support. And if we have this rhinological support, then in the step-by-step way, we can increase our indications, not only treating easy pituitary adenomas, but even other central skull-based tumors like this tumor here in a young child, 9 years old child with 3 previous surgeries. You see here the transcranial surgeries on the left and even on the right side, and still a large residuum of the tumor is a craniopharyngioma with extensive recurrence, headache, and visual disturbances. And this is the CT scan just before the surgery. You see even between the MRI scan and the CT scan, we see an enlargement of the tumor. And the question was, after 3 transcranial surgeries, do we have an option by a small child for the transnasal surgery? And our concept was a navigation-guided transnasal neuroendoscopic surgery. You see here the positioning of the child in the operating theater with neuronavigation, with the endoscopic equipment, and the preparation of the abdominal part for the skull-based reconstruction. The technique is uninostril approach, preparation of a flap of the nasal septum for the later closure of the skull base, and an endoscopic transplanum exposure with radical tumor resection. And this is now the video of the surgery. We are on the left side. At the beginning, we just see the nasal structures, and after deflammation of the nasal mucosa, this is the same approach with the ethmoidectomy, and this is even possible by the small child if the nasal cavity is very, very narrow. We are now preparing a flap of the nasal septum. This is a very important surgical step, because with this nasal mucosa, in the later course, we are able to close the defect of the skull base. And this is what you see now. This is an extended approach for the central skull base. You see here the dura of the anterior fossa. You see here the optic nerve and the carotid artery on the side. And now we remove the tumor with the pure endoscopic technique. My fellow holds the endoscope. I'm dissecting now in the cranial space. You see here even the optic chiasm here. This is the left optic nerve, the right optic nerve. You see the anterocerebral artery on the left side, on the right side, here the anterior communicating artery. This is the gyrus rectus, and we are now dissecting the tumor away from the floor of the third ventricle. This is here the chamber of the third ventricle, the hypothalamus on both sides. This is the thalamus here, and now the tumor is removed in a step-by-step way with the microsurgical dissection controlled with the endoscope and not with the microscope. And this is the end result of the surgery. You see here again the third ventricle, the foramen Monroe of both sides. If you look inside, this is the foramen of Monroe, both sides. This is the fornix, and in the background, the basilar artery. Now, an important step is the closure, and even through the nose, with endoscopic technique, we are able to use stitches. With the stitches, we close the skull base with sutures and with some fat tissue and fascia from the abdominal region. And now the very last step of the surgery, this is what I've mentioned. This is this flap of the nasal mucosa, which is now placed on the reconstruction of the skull base using fibrin glue. And this is the end result of the surgery. The nasal cavity is saved. And this is the middle turbinate. This is the ethmoid. This is the nasal septum. And this is the MRI scan on the first postoperative day. You see complete removal of the tumor. After contrast MRI scan, no remnant of the tumor. This is here the fat tissue which closes the skull base, and this is the nasoseptal flap and the skull base reconstruction. And this is the small child just 1 week after the transnasal surgery on the left side. If we have this technique, then in a step-by-step way, we can even increase of indications. This is a 51-year-old male patient with 2 previous surgeries and with an extensive tumor recurrence of the chondrosarcoma. And you see here the 2 orbits. You see in the central skull base the tumor, and the patient was in another institution in Switzerland, and the offered approach was a transfacial approach with exenteratio orbitae, that means with removal of the orbital content. But our opinion was that the orbit is not infiltrated by the tumor. This is just behind the orbit, infiltrating the cavernous sinus. But you see here on the coronal picture that the tumor increases into the middle fossa. And this is then the technical problem if you cannot overview this lateral part of the tumor resection here behind the orbit and behind the temporal bone. And in this case, we have performed even an occlusion test, because we're operating along the optic or the carotid artery. You see a balloon occlusion test that from one side, from the right side, even the left side of the brain is well supplied. The concept was a navigation-guided transnasal endoscopic surgery, uninostril approach, exposure of the cavernous sinus and the skull base, and preparation for an additional transcranial exposure with radical tumor resection. And this is what you see with the transnasal endoscopy. This is the removal of the tumor. Here the turbinates, here the central skull base, large part of the skull base tumors are removed through the nose. Then you have at the end of the transnasal resection here, you see the entire skull base. You see here even the pterygopalatine fossa. This is the sinus maxillaris. You see here the maxillary nerve. You see the structures of the cavernous sinus. Here the complete resection of the central part of the tumor. But from the MRI scan, we know that the tumor infiltrates even the temporal fossa, which is not approachable from this direction. And therefore, in this situation, we have extended the surgery with the transcranial approach. And this is here a small subtemporal approach. And here in the subtemporal approach, you see even a pure endoscopic technique. This is here the temporal dura. And even with the endoscope, we open now the intracranial part of the tumor. We are removing the tumor with a pure endoscopic technique, and then we reach the skull base from transcranially, not from transnasally, but transcranially. And this is the end of the surgery. This is the view with the endoscope to the transcranial approach, and you see the other endoscope coming from the nose. And this is what my fellow is able to see. He holds the endoscope into the nose. This is the maxillary nerve, and now I am dissecting transcranially with chiasm punches, with suckers, and you see now here even the dissection of the tumor from the temporal skull base. Here in the background, this is the carotid artery, this is the maxillary nerve, and we are now looking with the endoscope into the intracranial space, and we can overview the complete resection of the tumor. And this is the real cooperation between the renal surgeon and the neurosurgeon. I'm dissecting to the transcranial approach, looking on this monitor My colleague, Dr. Briner, is dissecting through the nose, looking on his monitor. This is the real cooperation of skull-based surgeons. And this is the postoperative MRI scan with the complete resection of the tumor, even in the temporal area, with normal quality of life of the patient. And now my conclusion at the end of the presentation: to pick the nose is beautiful. This is here in German, Nasenbohren ist schön. This is the translation. To pick the nose is beautiful. It was the favorite book of my son, because we have an optimally controlled dissection with direct visualization and free manipulation with the endoscope without using the nasal speculum. We can achieve the best possible tumor resection with minimal approach-related trauma of the patients. We can achieve acceptable operative risk and presentation of nasal functions and quality of life. It is very important to motivate neurosurgeons for nasal endoscopy, and this is a very, very difficult issue, because most neurosurgeons are familiar with the microscopic, not with the endoscopic technique. And I'm very glad to establish a neuroendoscopic group in the National Institute of Neurosurgery in Budapest. And you see this team, and they are here the renal surgeons in the team, and they are here the neurosurgeons of the team. And this is 6-3 in the operating theater, like the match of the century some years ago. Therefore, motivation of neurosurgeons, this is the most important issue. Évszázad mérkőzése of the well-known aranycsapat, the gold team of Hungary. So this was my short presentation on minimally invasive techniques and endoscopy within the skull base, overviewing the possibilities. Very important issue again, the best possible resection with preservation of nasal mucosa and nasal functions. Do you have any questions, Laszlo, or the audience?
Thank you, Robert, Dr. Reisch. A very interesting lecture. My question is, in my experience as a neuroendocrinologist, is that I've seen a few complications, and some of them weren't pleasant. One was a accidentally injury to the cavernous segment of the internal carotid artery with a massive MCA stroke. So walk me through why did that happen, besides the fact that maybe it was an inexperienced or a resident doing it. How often does that occur, and what's your thoughts about complications?
Yeah, the best management of complication is the avoidance of complications. And this is what you have seen, for example, in this very complicated case with the chondrosarcoma. Here we have performed the carotid occlusion test, and on the left side, because we knew that the carotid artery is running through the tumor tissue and the skull base. And in this way, we were able to know that we can close the carotid artery if we need it during the surgery. We use, of course, in every single case, a navigation device, and we prepare the team for the bleeding. Fortunately, in my team, we never ever had a carotid bleeding, but we know that it will happen because we are still operating along the carotid artery, and then you have to be well prepared for the severe complication. But even with the most experienced surgeon, if you increase your surgical indications, it can happen that you damage the carotid artery. Interestingly, this complication rate is less in endoscopic surgery than in microscope-based surgery, because the endoscopic operating surgeon is able to see the carotid artery. And if you see a structure, then you can save the structure, and you can avoid this critical complication. If you do not see a structure, then you can damage it, and it can be a critical situation.
Well, understood. So we have colleagues on the phone. If anyone has a question, you could either type it or ask it yourself. So
I have a question about the imaging, the role of imaging. I know you see that you're doing imaging navigation. Are there improvements or ways that you're using imaging in a virtual way ahead of the surgery to help understand where those complications may occur?
Yeah, we have the option to use devices of a modern neuro navigation equipment. And in a virtual reality, we are able to look for the anatomy of the patients by planning the approach. There are also some devices like the so-called dextroscope or the navigation devices of BrainLab and Medtronic, and we are able to look before the surgery by the planning procedure and see this anatomical details. Very, very important, even for young neurosurgeons, residents for preparation of the operation.
And is the quality of the source imaging what it needs to be, or can you imagine?
This is a 3D bone CT scan and the MRI scan without any specialties, and then you can fuse the images and you can use it for the operative planning. You do not need a real very, very special imaging.
Thank you. One question now. We have a very aggressive gamma knife team here where I work. What are your feelings of post-radiation surgery? Does that compromise your field? Does that cause you to have hesitancy in operating when somebody has had extensive radiation to the pituitary field?
Do you mean, Laszlo, surgery after the radiation treatment?
Yes.
Problem? Yeah.
Yes.
No.
Okay.
To tell the truth, no. We treat even patients, they had radiation treatment. Of course, the best option to remove the tumor as much as possible, and you don't need then the radiation or even a gamma knife treatment, because it was not a huge amount of residual tumor which needs conformal radiation, but just more remnants in the cavernous sinus.
And one more complication, because as a neuro-oncologist, I'm not in the operating room, I see the complications. CSF leaks. Yeah. What is your best technology in minimizing CSF leaks?
We have much more CSF leaks in endoscopy than in microscope-based surgeries because we are more radical in the tumor resection. We see the tumor and then we would like to remove the tumor. And the CSF leak is, in my hands, not a huge problem. It's not a real complication. This is an intraoperative situation which you has to be to manage. By smaller leakages, we use some artificial materials or abdominal fat tissue, or by larger defects. These tricks of for example, the nasoseptal flap. And in several cases, I have seen this case with the craniopharyngioma. We open the dura and we are dissecting intracranially. And then we have to close the dura. And for this closure, I use stitches, I use the special materials and the nasoseptal flap. If the patient has a high flow CSF flow on the skull-based reconstruction, then we use regularly a lumbar drain after the surgery for 3 days, but it is not in every single case a step.
Thank you, Robert. All right. Any further question? It's 12:47. It's late in Europe. And if no further questions, I'd like to thank you. Just a reminder, this lecture will be uploaded to the MIND website, mind.hu, so you can look at the slides afterwards and listen to the lecture. And Robert, I hope to see you in Budapest soon, and
yes,
I'm sure we will. So again, if no further questions, I'd like to thank you for your efforts, your time, and the audience. Oh, Janos, you have a question, Janos? You're a mute. Unmute yourself, Janos. That's it.
Yes.
Congratulations, Robert. And I just want to know how much in average, how much time in average during the surgery when the endoscope is held by the assistant and you can operate by-handed.
Yeah. To tell the truth, time is not the most important issue for me. The good surgery is not a short surgery. Good surgery is if you remove the tumor completely and you can save quality of life of the patients. And of course, a neuroendoscopic approach, the transethmoidal paraseptal approach, is more time consuming than the microscope based. I need about 30 minutes for the approach, for the transnasal part, and then again about one hour for the removal of a very normal pituitary tumor, which is with the microscope-based surgery about 40 minutes.
Okay,
I need more time. I need more time. This is no question.
Okay, I can agree, but completely, but probably I didn't expose my question percentage, percentage when you can use by-handed, or you can use one-handed.
You mean the learning curve of the surgeon, or
no? During these days, when you are experienced neurosurgeon endoscopically.
Yeah, I never operate one-handed. Some surgeons operate so that they hold the endoscope in one hand and they operate with the other hand. It's like you operate transcranially and one hand is in your pocket.
Yes.
Which I think it is not possible. You never would operate an EVM with one hand.
Okay.
Never, ever, I think. Yeah. And therefore, endoscopy.
So you need an assistant who knows what you need and is completely helpful.
Yes. We operate on this way that one of my fellow or a rhinologist holds the endoscope, and I dissect always with both hands, with the sucker and with my hands.
Thank you. I am very glad to hear this.
Yeah, it is
very important that it has been said.
Yeah, it is a microsurgical dissection with both hands, controlled by the endoscope and not with the microscope. But the both and the technique is for me very, very important. And it is a good question, because the most renal surgeons operate with one hand. If you go in the depth, if you dissect on the skull base, it can never work in my opinion. You need both hands. This is a very normal microsurgical procedure. It's controlled with the endoscope.
And most of the time, the other hand holds the suction.
Yeah, the sucker is your most important hand.
Yeah.
The sucker is the sucker, the dissector, the cleaning of the field. Left hand is more important than the right hand. And I'm absolutely sure you could remove János and EVM with one hand, because we know it, a giant of microsurgery, but I think the normal neurosurgeon need two hands.
Yeah, I agree completely. One last irrelevant note, that Pernetsky was born in Moscow.
In Moscow? No, not in Moscow. In Siberia.
In Siberia.
Siberia, yeah. And yeah.
He told me, because we were mate in the university in the first year. He told me in Moscow.
He was growing up in Budapest, and he was for me a very, very important mentor and teacher, my second father. I had a beautiful,
and a good friend.
A good friend. He was a good friend.
Okay, thank you very much, and congratulations.
Thank you, János.
Thank you, Dr. Vajda. All right. Any further questions from the audience? Otherwise, Dr. Reisch, thank you very much, Robert, and hope to see you in Europe. And thank you for the audience.
Thank you very much, László. Thank you very much for the invitation. It was a big honor for me. Thank you. Bye-bye.
Bye-bye.